Thank you very much, that was super. This now brings us on to the debate, which I'm sure you've all read. So today's debate, the pro-con debate, we should always take written consent before citing an epidural in labour. So before I introduce our two speakers, can I have a show of hands for those that are pro? We should always take written consent before citing an epidural in labour. I have one. This is not going to be difficult to count, is it? 2. So we know where the majority lies to begin. So the challenge audience, doesn't it? I'd like to introduce the two speakers. So for the pro side, the small challenge goes to John Osakue. John is currently He's talking first? That's fine. I'm still going to introduce you first. Is that okay? That's how I'm set up. So John's currently a senior anaesthetic trainee in the Hull Hub of Yorkshire and Humber Deanery. He obtained his undergraduate medical education in Nigeria and has amassed over a decade of experience in anaesthetics with a special interest in obstetric anaesthesia. He's had several publications spanning various topics within the field and has presented at local and international conferences. John got first prize for his presentation in the 6th All-Africa Anaesthesia Congress in 2017. Showcasing, I know, that's on a while, yeah. Regular violin, yeah. Showcasing his prowess as a researcher and a presenter. Beyond his professional endeavours, John's deeply committed to volunteer work, actively engaging in activities that contribute to the well-being of his community. He's also a skilled live sound mixing and reinforcement technician, showcasing his diverse talents beyond the realm of medicine. Married with 2 children, John cherishes quality time spent outdoors with his family, emphasising his dedication to work-life balance and his love for family-centric activities. So that is John, with the challenge, I feel, at the moment. But here comes James Turnbull. So James is a consultant. We'll give him a little clap because we did for John as well. Anaesthetist at Barnsley Hospital. After embarking on a career as a hospital clinical pharmacist, who knew, he made the move to medicine and then ultimately the correct decision into anaesthetics. His anaesthetic training spanned the Yorkshire Deanery, including an enjoyable time spent in the East Yorkshire region, but he's ultimately settled in South Yorkshire where he still lives. At Barnsley, he's part of the obstetric anaesthetic and pre-operative teams in addition to the general duties of a DGH anaesthetist. His other activities include being college tutor, his trust undergraduate sim lead, and departmental lead for sustainability. So I didn't think he would have any time, but seemingly he does, and he enjoys cooking world cuisines, riding motorbikes, and the Star Wars universe. Yeah. Oh, the temptation that I won't do it. Okay, I leave you to it. Thank you.
Good afternoon, everybody. I sound quite loud from here, is that okay for everyone? So my name is James Turnbull, and what I'd like to say is that for the ladies and gentlemen of the debate jury today, what I hope to impress on you in 33% less time than I thought I was getting is the notion that beyond all reasonable doubt, this statement here is nonsense. Okay? I hope to do that within the next sort of 10 minutes. Okay, so a couple of disclaimers first. First of all, I am not a medical legal expert at all. The opinions you're going to hear today are based upon some reading that I've done and my opinion of them, and also the fact that our President-elect told me to pick a side. So, we'll start off with a hypothetical scenario. So, as you heard, I do pre-assessment, so I do love doing extra paperwork. So any opportunity to shoehorn more in, I would be usually in favour of. So how come I'm taking the con side? Well, we'll look at this with a hypothetical scenario, briefly. 28-year-old, fit and well, 37+1, nulliparous, traumatic obstetric history with the previous IUD, she's now undergoing an induction. She's 4 centimetres. She's really not tolerating contractions already, requesting an epidural, and I'm informed the CTG is okay. So, I go to see the lady. I take a verbal consent for my epidural, ticking a few boxes on my form as I go. Get it in first time, pretty happy with that. And give a test dose and then top it up to 20 mils. And it's at that point the obstetrician comes in and tells me that according to the new criteria, the grumbling tachycardia is now pathologically dangerous and we're going to have to go straight for a category 1 section. So I'm thinking, oh no, I might have to do a general anaesthetic here. The surgeon is thinking, I need to take some consent. And she knows that she's going to have to get a signature for it because the theatre team will not let her into theatre. So she thrusts the consent form in front of the traumatised lady, distressed and not listening, demanding that a signature is put on the form, and then we wheel her down the corridor towards theatre, and I have 30 seconds to talk to her about pressure on her neck and chipping her teeth. So there's 3 forms of consent there in a short period of time. We've got a somewhat controlled verbal consent for an epidural, a arguably forced signature in a distressed woman, and then another verbal consent for a general anaesthetic to which nobody was listening, possibly not even the audience. So what is consent? Well, I'll be very brief on this. The GMC tells us what consent is, and it actually stipulates 7 principles which define consent and should be considered. Now, for brevity, I'll just trust me that the first 4 effectively relate to shared decision making, 5 and 6 relate to capacity, and the 7th relate to those for whom their rights are affected by law and we'll consider outside the remit of this discussion. So what defines consent? Well, you can read it, right there. Ethics defines consent, but also law defines consent. And in fact, the 2 go hand in hand, and in fact, the law often ultimately defines what our ethics is. And the 2 work together to provide what our guidance is. So, given that, we should probably follow the ethical and legal learned opinions. So what does the guidance say? Well, predominantly it's going to talk about shared decision-making and capacity, because the GMC's already told us that. They say that we should give patients the information they want or need to make a decision. They say that that information should be objective and explain the reasons, including doing nothing. And they say that we need to keep an accurate record. They even go on to talk about consent forms, which they say can be helpful, but aren't a substitute for meaningful dialogue. So that's what the GMC would then classify as the summary of consent making. There are other forms of information as well. Fortunately, my go-to resource, the BJA, has produced an article on this, so that was the first place to have a look. And it summarises the consent process, the evolving consent process, and is up to date to about 2018, which is valid with regards to the legalities we're going to talk about. The most relevant aspect to the debate today is the summary of the AAGBI guidance, which suggests that separate written consent is not required when facilitating anaesthesia for another procedure. It then follows that up by saying it's good practice to contain written consent for independent, autonomous procedures. So we can have a look at this by going, perhaps we should have a look at the AAGBI guidance to see exactly what that says, because that's the summary there. Well, the AAGBI guidance agrees that you should have a separate consent form that a consent form for facilitating another treatment is not mandatory. But actually, it doesn't say anything about written consent in the AAGBI guidance. So where did that come from in the BJA, I wonder? Because actually, the word written consent doesn't occur anywhere in that article. So maybe I was looking at it wrong, and maybe we should look for the word signed, because people could use that analogously, signed consent. So we get 6 hits when we look for signed consent. The first talks about the documentation for anaesthetic procedures facilitating another treatment, but it says that the consent process is important, and a signature does nothing to validate or invalidate the consent process. And in fact, it goes on specifically to comment that where that anaesthetic procedure may be considered part of a large component, in this case labour epidurals for childbirth, signed consent is not required. So AHB guidance, pretty firm on that one. Where we can look at some grey areas perhaps is where the anaesthetic technique is the primary intervention. And here actually epidural blood patches do get a note. And they say here that local procedures should be followed and acknowledge that some trusts mandate a written guidance. But that's the trust mandating it. And the AHGBI guidance says that local procedures should be followed. The only place where we get an actual firm recommendation is in chronic pain, where in chronic pain interventions, as an autonomous independent practitioner, it recommends but does not mandate written consent. So let's have a look at the legal considerations. What do we need to know about that? Well, it's complicated. Fortunately, the GMC has produced this nice little guideline for me, which again, like the BJ article, gives you a good starting point. It looks at 7 cases related to key law and legislation. 2 relate to effectively shared decision making, 5 relate to capacity, but none directly relate to written consent. It would be remiss to do a talk on consent without talking about the Montgomery case. I won't go into the details again for brevity, but effectively this is the obstetric case about an LGA baby with a vaginal delivery which was complicated, and it has resulted in changes in our shared decision-making processes due to overruling by the Supreme Court of the traditional consent Boland criteria, and now we go for a more tailored approach to consent based upon this case. But is there anything specific we can talk about? I've lost my cursor. Oh, here we go. Is there anything specific about written consent that we can gauge in this case? Well, actually, there is. Because if you do a deep dive into the guidance here, you can find this statement, which says, a doctor's duty is therefore not fulfilled by bombarding the patient, let alone routinely demanding her signature on a consent form. Interesting. Another case, Fafout versus Johnson. This was a case about a lady who had decompressive surgery for neurological symptoms which didn't work. Ultimately, the courts ruled in favour of Mrs. Fafout, stating that the surgeon had sort of over-egged himself with what the likelihood of good outcomes were in that case. Is there anything we can think about written consent in this one? Well, again, there is. Because in this case there was a written consent form and it was signed, but the written consent form had little or no evidential weight overall with regard to the outcomes of that trial, irrespective of the fact it was signed. We can look at another case. The breast surgeon, Ian Patterson, convicted of multiple acts of mutilating patients over a 13-year period in 2017. All the patients had signed a consent form, but that consent was based upon false information. So it cannot then be that a signature represents a robust consent process. The consent process itself must be the more important thing. There we go. Welcome. Sorry, there. This is a legal term. It's in Latin, verba volant scripta manent, which means spoken words fly away and written words remain, and that is true. But in law, written words can only be used to supplement the case. They can't represent it. And all the cases we've looked at have talked about the quality of consent, and a signature acts as no proof of quality. We'll have a look at, I'm not going to talk too much about capacity, just to acknowledge that it's significant that the AHGBI discussed the issue of its presence in labour, but we presume that the women have capacity. But what it does say is labour is the wrong time to burden women with excessive information, and it highlights, the concerns about the validity of consent in an emergency. So does a surgeon's forced signature actually carry any weight? So in summary, I will say that there is no legal or ethical requirement for written consent for epidurals, except arguably for epidural blood patches. Actually, I would say that written consent misses... Oh, hold on. Where's that gone? Written consent misses the point. Every one of the legal and ethical cases we've looked at is about the quality of the consent process and the shared decision-making and capacity as the predominant factors. So, there we go. And one of the key points in this is the time given to a person to have consent. From the Fout case, which I didn't mention, one of the key points was that the woman was not allocated appropriate time. So, which you're not going to get necessarily in an emergency, and a signature certainly doesn't force that. So, the actual question is the consent process for epidurals valid at all, whether it's signed or not? Like, how can we assure and document effective shared decision-making at the time of the peripartum period? That's the question for me. How can we ensure we give information and the timeliness for a woman to process it? That is, for me, the key point, more than whether the signature is present or not. So with regard to our hypothetical scenario, I repeat the question then. Which of the three consent processes there do you think would be increasingly validated by the presence of a signature? I would say possibly none. I'm going to conclude with a comment from my esteemed colleague, Dr. John Maskell, who has a degree in law, runs a medico-legal course, and obviously has a interest in the medico-legal. He's also quite brief and up to the point. And when asked this question, I said, he gives this comment. He said, "The only legal document which requires a signature is a deed. Consent is not a deed." I rest my case.
While Wayne is setting up, I must confess that I've been given a very hard task. And when we did the poll earlier, I realized that I was even more in for a horrible time. We had a meet yesterday, with me and James online just to go over things. And I must confess, he was a lot more congenial at that time than now. He really dug the knife deep this time. So while that's getting set, we've just done a quick poll. We realized that not many of us practice written consent. I was prepared for that anyway. And I could potentially say that James already ended the argument, or started the argument for me with his last few slides, where he talked about, the Latin. I'm barely fluent in English, much less Latin. But it made the case on my behalf at that point that, written words remain, but verbal flies away. So I'll start off from there and just say, first of all, I'll be going through this outline as much as possible. I also have no conflicts to declare other than the fact that I've practiced a bit in Sub-Saharan Africa, where it was a lot simpler doing these things compared to here. And being an IMG as well also puts me at a higher risk of getting into problems with GMC and with that's a bit of my bias here, looking at this argument. So consider that when we talk about this. So, what is consent? What comes to mind when we talk about consent? I imagine the picture that comes to your mind is that there's a document somewhere. And I know we do have a lot of persons who probably will not agree with that. But we are not just looking at it from our side of view now, we're looking at the side of view from the patients as well, holistically. What does the patient think about consent in the first place? The more educated you are, you sway towards our side of view, but a lot of our patients may not be that well educated, and they will think of this as their own definition of the consent process. He's made the argument, consent is not a single event. So just having a signature, as it were, does not replace everything that needs to take place. It is a continuum, and that's exactly what I'm going to be looking at it from. That the fact that I am not saying replace everything with a signature, but does it help? Does it supplement what we have? Does it make it better, basically? So I decided to look where everyone looks these days when they look for information. go to AI. So I asked Meta AI, what is consent? And all that came reading off the screen. Written consent and verbal consent, both different ways of looking at things. We know what verbal consent is, we know what written consent is, and then it goes further, says what's the key differences between them. Talks about documentation, the fact that it provides a good paper trail. That legal weight there could be argued, but it depends on, legal arguments are about who the lawyer is and how well to speak about these things. And clarity as well is also an important part. Unfortunately, you can see how much task Dr. Reina gave me when she put me up to this task. Being up at 3:02 in the morning trying to go over this morning. So thank you. What are the legal perspectives? Again, James has done a fairly good job of this. And I put this here not because I want to go through all of them, it would be repeating a lot of the facts that he's already stated, but rather to emphasize that things have changed over the years. A few decades ago, it was the Boland Principle, a respected body of competent medical professionals. And now we've moved on to Montgomery, where, what does the patient really want to know? What applies to the patient? Who knows what is going to be in another decade or two? Will things change? Will the opinions of what we hold as certainty now change? And unfortunately, in the court of medical opinion, we find that we are judged by what is applicable at that time, rather than what was applicable at the time we made our choices, which seems to be the case. Case in point, the recent, what's been in the news about the tainted blood and all the other stuff that's been in the news lately. Well, I'll leave you to try and decide all of that. Looking at what has been published, what's been written, consent during childbirth, in the Journal of Medical Ethics, where this specifically relates to episiotomies, I lifted a few paragraphs out of there. It says, maternity care is one of few areas of medicine in which treatments involving risk to one patient, but are largely, with the sole aim of benefits in one patient, but largely impact the care of the other person. Again, I'll bring this reference when we talk about one of the examples I cited here, a GP who got sued by a patient, or the daughter of a patient he had several years afterwards, because he had not, in quotes, educated the mother enough about the benefits of folic acid supplementation. So 10 years, 20 years down the line, imagine you sitting in your office and getting a letter from one of the babies you delivered from your epidural and saying that, oh, you didn't tell my mom about this, and how would you prove that you actually did? But why do we need to look at this? What's the reason? Do we really need to be looking at the whole process of consent, basically? We perform, according to NAPRI, over 700,000 central neonatal blockades every year, and 45% of these are done in the obstetric units. So that's quite a number of procedures being done regularly. I looked at what the MDU guidance was, obviously, whenever we run into problems, we bring these guys and see what their opinion is. One of the points they made there is that a lot of the complaints, significant proportion of complaints, arise from consent rather than anything else, rather than the actual procedures that have been done, rather than complications that are relating to consent. And largely because the patient population we deal with are those who are considered at-risk population because they are young, usually fit and well, and have very, very high and sometimes unrealistic expectations of what's happening. So does that mean we need to exercise a bit more caution? Does that mean we need to be wary of what comes after a few years down the line? This editorial was published in the Journal of Anesthesia several years ago, and the MP2 was the editor, associate editor at the time, wrote a follow-up to that, just to the end, basically describing our experiences on the obstetric anesthesia unit. You go into a room, oh, hello, I heard you want an epidural. I'm just here to give you all this. Just put it in! Stop talking! We all go through this a lot of the time. And we generally tend to oblige the patients and go ahead and put the epidural in. Oh, I hope you understand all of this. Yes, 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 yes. And then 2 weeks down the line, you get a complaint in the mail saying this and this happened. And but but I actually did get your consent. No, you didn't. It becomes a you said, he said, who do we believe? So it becomes basically a burden of proof on you trying to actually say that, yes, everyone says document the notes and all this. Again, you talk about paperwork, an extra set of paperwork. Could we increase our chances, or rather a better patient's memory, improve patient's memory by getting them to actually do an extra piece of paperwork, saving us that extra headache a few years down the line, basically. In his opinion, MP's opinion, he says written consent, providing written consent will probably improve patient's memory, but we'll look at what has been done afterwards to see if it really did change things. Again, I've talked about all this, so I'll skip that bit. I've talked about human memory is the best for me, especially when it comes to times when you've got pain. Be clouded by that pain, you just want to get out of that pain. And then, can we really rely on their recall at that point to say that they provided consent? We're not arguing about validity of consent here. We agree consent is valid in label. That's no argument there. But recall is what we need to be talking about here. So is written consent a thing? Am I just bringing this, where did this argument come from? Is it just something that's we plus straws, maybe? In Korea, about 85% of their consents for epidural are documented, written, signed. In the USA, 50 to 60%. In Australia and New Zealand, 16%. In the UK, 7%. So you agree that the practice is far varied wherever you go. But the question is, does this distribution reflect to the level of litigation in each of these societies? That's the question. And are we heading down the same way as most of these other countries that's required, that's made them change their practice, basically? So there's this publication here by DJ Bush to talk about a comparison of informed consent for obstetric, comparing the USA and UK, and that's where the data was taken off earlier. It talks about the fact that over the last few years, there's an increasing trend towards written consent, especially in North America rather, and asking, should we be looking at also changing our practice just in case we head down the same line? The response rate was fairly similar for both populations, and so the results were valid and the p-values were very statistically significant. Looking at the NHS litigation claims and analysis of that done by TM Cook several decades ago, there's been another using more recent data on this, and basically suggests that anesthesia on its own isn't doing badly where it comes to complaints and litigation. I mean, numbers-wise, we're sitting pretty well in the middle of the pack, but obstetrics seems to be sliding out in front. And if that's the case, then are we being bunched up in there somewhere as well? Looking at financial numbers, it also shows that obstetrics takes the bigger role as well, paying out a lot more money than any other specialty. And could we be brought into those claims as well again? Now, looking at that data in more detail, you find there that obstetric anesthesia, looking at for anesthesia complaints now, obstetric anesthesia seems to be ranking up 7 compared to just after regional anesthesia, but we're paying out a lot more money compared to any other of the fields of anesthesia. So all this just asks us, should we exercise a bit more caution? Are things going to change a few years down the line? What should we be doing basically? James has talked about this already. Look at those guidelines for anesthesia and consent. My argument on this, while we say that a separate consent form signed by the patient is not required for anesthetic procedures that are done for facilitating treatment, could some smart lawyer actually argue that your epidural is a standalone procedure in a patient who's coming for labor, which is uncomplicated? That's something I would want you to think about. I mean, yeah, I'll leave it at that. These few authors looked at an evaluation of informed consent prior to epidural and the GCM label. It basically tried to look at the ability to recall information given, comparing patients who were required, who had verbal consent taken and those who had written consent taken. It clearly shows that those who had written consent had a lot more recall, better recall compared to those who had verbal consent. That's in the print. That's not my opinion. This follows on from work done in the 70s, which I think informed a lot of the change among the surgical specialties in moving from just going from verbal consent also to written consent. These works were done, like I said, in the 70s. They demonstrated clearly that for patients who had to sign a piece of paper, they recalled a lot better what risks were explained. And also maybe because they also get to take a copy of the consent home with them as well. So should we be reevaluating our own stance as well? Now, moving on to more contextual arguments. If the obstetricians do, why don't we? Even for a Part 1 section, like he's explained, they still will get the lady to sign that signature on paper. So what is our argument? Time? No. I agree that it's just another paper, it doesn't hold weight. But again, some lawyer would say, if your other colleagues did, why don't you? How can we say that you've actually told this patient what you say you've told them when they didn't sign anything? And then we do it for an epidural blood patch anyway. So what's the excuse not to do it for our routine epidurals for label? Is there a need for us to change? We totally agree that the written consent is not a replacement for the consent process. It merely facilitates or improves that consent process and helps the patient's recall of the information provided. So, given these following things I've mentioned, do we need to be considering a change? Big is the new normal. Our patients are getting bigger, BMI-wise, and you could anecdotally say that therefore there are more risk of complications developing from our interventions as well. If that's the trend and which is increasing, then should we be looking at also protecting ourselves a bit better by improving that process? The court of public opinion is gaining more weight with social media. Before it even goes down to the courts, with the Supreme Courts, they've already decided pretty much our guilt or innocence in the court of public opinion. Would having some signature helping your recall probably give us a little more wiggle room to make our arguments when these get to the court of public opinion, basically. There's increasing training needs such that we are having, safe to say, more inexperienced trainees help out on the delivery suite. And then the scope of practice for the anesthetic associates as well, helping out on some units as well. It could be argued by the distinguished legal minds as well. If you're getting non-consultants doing these procedures, how can we be sure that they've actually kept up with giving the same amount of information or standardizing that process as well as you say they should? And then we have this minefield, which is called the law, which seems to be evolving at such an amazing, awesome rate. And its interpretation is just bewildering because you only need two persons differing on that Supreme Court justices, and then they're, no, this doesn't hold weight. We should probably change the way things go. So, given all of this, what should we be doing? Remember the example I cited earlier about the patient who sued the mom's GP for that. Could this be us a few years down the line having to respond to these sort of cases and answer them? So how do we navigate this minefield? We have to stay up to date with legal and ethical developments, collaborating with legal experts, getting them in to have chat with us and also discuss how we can improve things. And then I'm going to highlight here anticipating and adapting to changes as well. What are these changes we need to be adapting to? So how do we foolproof the future? That's looking at the changes now. Awareness campaigns by dispelling the myths, talking to these patients before they come in. We've had several talks here about patients who have different impressions or hold some interesting ideas about epidurals causing back pain. We know that published works have indicated that a lot of information patients hold comes from family and friends more than any other source of important literature. Rating of radiographic information in the perinatal and antenatal period. That will definitely help with improving the consent process as well. And in my opinion, having a signed document would go a long way as well to, we're taking copies for the patients. It's been shown, not just my opinion, but several researches which we've quoted already have shown that you would improve their recall when they put their signature down and take a copy of it home as well. Clear documentation of our interactions and routine documented follow-up of all patients. So, where do you stand? Is it at either end, or should we seek a middle ground, basically? You may not, I'm not telling you to completely replace everything by signing a document, but I'm saying we'll have a signed paper improve the entire process, which we are currently using. Thank you very much for your time.
Thank you both. So we'll redo the poll. Now I've forgot my crib sheet, but those in favour, of always having signed consent for an epidural. Oh, good man, John! That's it, we've had an improvement. And those against? I think the against still hold it, but thank you so much, very entertaining.